العيل بقى يا اما بيصرخ يا اما بيرفص، انا هفحصه ازاي؟ انا هعمل ايه؟ ازاي اوصل لكده؟ النهارده الدكتور ايمن هيبسط لنا الكلام ده خالص، وهيغير لنا البرسبشن بتاعنا على هاو تو اكزامين ا تشايلد. النهارده محاضره باذن الله هتكون ثريه جدا ومفيده جدا، سواء في عيادتك او في امتحاناتك، في الامتحانات برضه. دكتور ايمن حضرتك منورنا كالعاده، واتفضل حضرتك. ننبه بس، سوري نسيت انوه على محاضره بكره، محاضره يوم الاثنين. احنا محاضره يوم الاثنين دي اللي هي اخر واحده في رمضان باذن الله، هيكون معانا البروفيسور دكتور نيكولاس فال، وهيكلمنا على الاوبتيك نيورايتس اند بابيليديما مودرن ثينكينج اند مودرن ايميجينج. دكتور نيكولاس ده الشيرمان للاوفتالمولوجي ديبارتمنت بتاع النورث ويسترن يونيفرسيتي، وباذن الله يعني this is a very eminent international speaker، واحنا يعني جبناه لكم مخصوص عشان الناس كانت عايزه حاجات في النيورو اوفتالمولوجي اكتر، فقلنا نجيب حد بقى انترناشونال سبيكر برضو يدي امبريشن كويس ويدي معلومات ريفريشن. دكتور ايمن بقى معانا النهارده، وهيقول لنا بقى احلى كلام في قصه how to examine a child tips and tricks. اتفضل يا دكتور.
أهلا وسهلا، مساء الخير يا جماعة عليكم. رمضان كريم. Good evening everyone. I'll try in this lecture, actually some of this lecture will be in Arabic. So for those who couldn't understand Arabic, still will be able to follow the main idea and the main points in this lecture. But there will be some Arabic expressions while we are going. Okay? طيب انا برحب بيكم، مساء الخير عليكم، رمضان كريم. جايب الفانوس بتاعي جنبي اهوت وجاهزين لرمضان، وان شاء الله يا رب تستفيدوا من المحاضره ديت. المحاضرات الحقيقه اللي انا شخصيا بستمتع بيها جدا، محاضره لطيفه وجميله وانا يعني بحبها يعني. فنتوكل على الله ونبدا ان شاء الله.
اتفضل يا دكتور ايمن.
اوكي. طيب how to examine a child. طبعا احنا يعني في الايرا اللطيفه بتاعه الاونلاين دي لطيفه، وادتنا فرصه الحقيقه ان احنا نقعد مع بعض اكتر ما كناش بنعرف نقعدوا الحقيقه في الريال لايف، في البراكتس كنا مشغولين طول اليوم. فالحقيقه دي من المميزات البسيطه ديت يعني. في المقابل الاونلاين ميتنج ليها شويه سايد افكتس، يعني مثلا زي ما فاكرين انتوا اللقطه الشهيره دي اللي كان بيعمل ريبورت ودخل اولاده دخلوا عليه في الاوضه، وكانت حاجه لطيفه ودمها خفيف جدا. فطبعا ده ممكن يحصل في اي وقت، فدي حاجه ايه ما تزعلناش يعني، لان احنا مش متعودين قوي ان احنا نعمل شغلنا بشكل كامل كده من البيت يعني. الاونلاين ميتنج كمان لطيف ان انت بتبقى لابس ومتشيك، عارفين كل اللقطه اللطيفه دي بتاعت الفيلم الجميل ده اللي انت تبقى بس اللي باين فيه. فقبل ما نبدا بس كده عاوز اكد بس على حاجه، ان احنا بليز عشان نبقى مركزين هنقفل هنتاكد ان الحاجتين دول مقفلين، الصوت والكاميرا بتاعتنا، عشان الكل يركز بس في الصوره بتاعتي والكاميرا بتاعتي وانا بتكلم. فهتاكد ان معمول علامه الانميوت وعلامه الايه والفيديو يكون مقفول، يعني المايك عليه شرطه والفيديو عليه شرطه، ماشي؟ عشان ساعات بيحصل غصب عنك بتدوس على الفيديو فبيتفتح الفيديو، فايه تلاقي في ناس دخلت كده بالفيديو وكانها داخله كده علينا تقول السلام عليكم، فده بيبان وبيظهر في الريكوردنج بتاعها بعد كده. فنحاول ناخد بالنا الفيديو بتاعنا والمايك ما يتفتحش علينا كده غصب عننا. هيبقى في شويه اسئله واحنا ماشيين. الاسئله ديت حاول تكون يعني يس اور نو او اجري وديس اجري، وانتوا هتلاقوا اوبشن عندكم في اختيار يس اور نو، فيعني يبقوا شاركوني معاكم كده ونشوف النسبه طول ما احنا شغالين. اول حاجه انا عايز اتاكد بس من الشات ان احنا الصوت بتاعي واضح وصورتي واضحه، فعايز اتاكد بس ان الكلام ده موجود. كويس، انا شايف ان هو كل حاجه واضحه وكل حاجه جميله. طيب هنبدا باول سؤال. اول سؤال خالص، هل انت من هل احنا في ناس عندنا من النوعين اللي هو ايه، زي ما قلت كده ساعات الواحد بيحمل هم قوي كشف على طفل، فانا لا يا جماعه انا مش بكشف على اطفال، لو جيت طفل اوديه لدكتور عيون اطفال هل ده انتوا كده؟ فبليز answer this question yes or no. Are you one of those who don't like examining children, and when you face the child in your clinic, you just try to send them to a pediatric ophthalmology, which is not a crime, by the way, but let's see the poll. Say yes or no. Interestingly, a lot who said yes. Interestingly, but the majority is no, of course. Okay, that's great. So, how to examine a child like this very cute kid? First, you have to know that the child, is the kid just a small adult? No, it's not just a small adult who started to be small and then turned to be big. Sometimes the kid shows too much action for examination. Sometimes وبنشوفها فعلا بتقابلنا المواقف ديت وتبقى يعني فيها اكشن زياده عن اللزوم شويه. And sometimes much less action وساعات العكس قال لك نايم خالص عايز تصحصحه وعايز تعمل له examination. فهو دايما السؤال والمحك في الموضوع احنا الفيرست كيك ايه؟ اول خطوه لينا ايه في الطفل لما بيجي؟ الحقيقه الخطوات بتبدا في كذا حاجه بتبدا بدري قوي من اول الفايل. يعني الطفل اللي هو داخل ده قبل ما يدخل الطفل لازم انا اكون بصيت، لو هو متابع طبعا اكون بصيت على الفايل، ولو هو حتى اول مره بشوف الايدج او متخيل انا داخل على وضع زي ايه. الاسيستنت بتاعي بيديني فكره، هو كان كبير وكان متعاون مثلا يقعد على الاوتوريف او ما كانش متعاون، فباخد فكره شويه اللي داخل عليه ايه. لو هو متابعه لازم ببص على الفايل بتاعه. I have to see the medical file to have an idea. الحقيقه برضو من الحاجات تيبس اللطيفه اللي احب ان انا اقولها لكم ان في الفايل بكتب شويه كومنتس من ضمنها مثلا لو حصل حوار مثلا ان هو بيلعب رياضه معينه مثلا and he is very good in a certain sport، فبتبقى لطيفه قوي ان انا في المره بعد اساله اقول له عملت ايه؟ انت كنت داخل بطوله نجحت فيها ولا لا؟ ولا عملت فيها ايه؟ فالحقيقه الحاجات دي انا بحاول اكتب في الفايل بتاعي شويه الهنس الصغيره دي، فبتفرق قوي لما تيجي المره بعدها وتقولها. فالحقيقه بتفرق جدا. الطفل نفسه بيبقى جاي بيدور على كده. يعني كتير الطفل بيقول انا جاي عايز اشوف صوره الورده اللي انت وريتها لي المره اللي فاتت، انا شايفه مثلا من سنتين مثلا بس فاكرها ومستني. فالحقيقه برضو من الحاجات اللي احنا لازم نحطها في بالنا هي الحكايه دي، ان احنا نبص على الفايل ونشوف الحكايه. طبعا في ناس طالبه تتكلم انجلش، ف I'm just assuring you that the most important word and instructions will be in English, but there will be some Arabic expressions. Okay. So the first thing is early communication. As soon as the child enters the clinic, the early communication is a must. That's very important. الدخله الاولانيه على الطفل عليك مهم قوي، ازاي تتعامل معاه وتكومينيكيت معاه. الحقيقه ان انت تبتدي تعمل معاه كونتاكت، تبتدي تتكلم معاه بشكل كويس، تبتدي تتكلم معاه بشكل لطيف. يعني كتير قوي بيجي الطفل يخش العياده، كنا مثلا لسه بكتب فايل المريض اللي قبله مثلا كويس، ساعات بيحصل الحكايه دي. لا هم على طول لو ده دخل وانا لسه اكسبكت كنت لسه مستني عشان يخش دلوقتي، بسيب على طول اللي في ايدي وعلى طول ابص ناحيتهم اللي داخلين، عشان الابتسامه اللي بيشوفها علينا بتفرق جدا. Just give the child a smile. This will make يعني say a lot for this. تديله سمايل، ترحب بيه بشكل كويس، تكلمه كلمه حلوه، تمدح حاجه معينه فيه، حاجه هو لابسها. الحته دي الحقيقه مهمه جدا. يعني تكلمه مثلا ايه what's this nice shirt that's a very nice flower in your clothes، التوكه اللي انت لابساها دي حلوه. الحقيقه الحاجات الصغيره دي بتفرق جدا وبتفك الطفل بشكل كبير قوي. فالايرلي كوميونيكيشن بيبقى مهم. في اطفال بقى ساعات بيبقوا يعني مغلسين شويه، غلسين شويه، قلقانين وخايفين ومرعوبين. ممكن ساعات في الاول اللي بيحصل ان انا بوجه عيني ناحيه البيرنتس الاول. look to the parents first وstart talking to the parents لغايه ما التشايلد يحس ان هو ريلاكس وان هو مش في السنتر بتاع الحدث، لان هو بيحس ان هو في وسط الاحداث وهو السنتر اللي الطفل مركز عليه ساعات بيتوتر اكتر. لما تحس ان الطفل اتوتر زي كده خلي كلامك مع الاهل وانت شايفه في البريفرال فيلد بتاعك. Hi, one of the nice tips, if you are in the clinic and you have a camera in the waiting room and you have it inside your room, you can have a look on the behavior of the child outside and you know which is cooperative and who of them is not cooperative. فالحقيقه الايرلي كوميونيكيشن مهم وبيفرق، والابتسامه اللي في اول ما الطفل بيدخل الحقيقه بتفرق كتير قوي. ماشي؟ فالحقيقه دايما اقول كده a few seconds playing with kids in the beginning save tens of minutes in hard examination and give hundreds of infos that could not be reached by force. اوعى تفتكر ان انا هات الولد وكتفه ان انا هعرف اجيب معلومات اكتر اطلاقا خالص. فلازم لو سمحت الحته دي خد وقتك شويه في انك تلعب. دي كلمه حلوه، كلمه جميله، الله شوف الحاجه الحلوه دي، شوف انت ايه اللي انت لابسه، ايه الجزمه الجميله الحلوه اللي انت لابسها دي. كل ده بيفرق جدا. it helps a lot. play some time few seconds هتبقى تمام. الحاجه الثانيه المهمه ان most of the children, most of our pediatric patients, they are chronic patients. Most of them are chronic patients, which means that this child will come once more and more, and maybe for more than 10 to 15 years will be continuing following with me. So we have to make a relation as soon as possible. So if just by force كتفوا الولد خلينا نكشف، هيكره المكان، يجي المره الجايه كاره المكان، كل زياره هتبقى مأساة. انما اول زياره تحاول تفك وتحاول تلعب معاه، الزيارات اللي جايه هتبقى احسن كتير، تبقوا اصحاب تكمل رحله معاه كويس قوي. غير ان في داتا ما تعرفش تاخدها بالعافيه. يعني في حاجات بتبقى انت عايز تشوفها براحتك، عايز تشوف موتيليتي براحتك، عايز تقيس زاويه الحول بالعافيه وبالتكتيف، دي بتبقى صعبه. فانت بتفكها كده تبقى لطيف. The problem that we have faced now in the era of the COVID-19, this communication, this communication has been affected in this era, to be honest. This appearance scares some children by putting a face shield, by putting a mask, the mask mainly actually. Even whenever I remove the face shield and just keep the mask, it's still the smile is not the same. I try to deliver some eye contact, to deliver how I am smiling from my eyes, but still we have really, this affects the communication with kids. I can feel it in the clinic. The face shield also is difficult in examination. Doing retroscopy, putting in direct is quite not easy, but so as much as you can. But of course, the mask, there's no compromise. I let the patient put mask, I put masks. Okay, sometimes approaching an uncooperative child like this is considered by some people as mission impossible. It's not always like this. The main thing and the gold stone is how to handle with uncooperative child. Like when you face a child like this, crying, very uncooperative, as I mentioned, some few words, some nice things. Allah, ايه اللبس الحلو اللي انت لابسه ده؟ ايه الحاجة الجميلة اللي انت لابسها دي؟ Show me what's in your hair. Show me what's in your ear. You are very good boy, just such a good boy, and can show some cartoons. Look at the cartoons there, and then in very few seconds you turn to this appearance, and you have a very cooperative child. Okay, you can take any kind of data that you want to get. The age group, of course, is a very crucial factor. Kids is huge. Children is a huge spectrum. The age group differs completely. How to approach each age group. A baby differs than preschool child, a school age, and of course a teenager. You know, the pediatric age group can be considered up to 14, 16, or even 18 can be considered pediatric age group. So this completely different approaches. For example, a baby, the baby is usual. For me, a baby is much easier in examination because the baby or the newborn or the infant has very few bad experiences in his mind. So like he is not scared by definition. So any sound, light, things like this can easily attract his attention. So I think the baby is one of the most suitable. But the preschool age, I mean, like 3 years, 4 years, for myself, this is the most difficult, because if you have an infant, he doesn't have a bad experience. When you have an old enough, like 7, 8 years, you can communicate and convince him. You have to do this test, this for you, this, you can convince him. But for the 3, 4, it's not big enough to be convinced easily. And he is not very young that has no bad experience. No, in this age, 2 years, 3 years, they have a bad experience of injections. How many times they've been told by the parents that we are going just to play with someone, we're going to take picture, we're going to have a personal photo. كتير قوي بتحصل الحكايه دي، تلاقي جايين نتصور، طبعا دي بتبقى مأساة. جاي يتصور، وكم مره حصل معاه قبل كده اللي له هنروح نتصور وخد حقنه عند الدكتور كتير، فهو ما بقاش يصدقهم، بقى خايف منهم، بقى مرعوب منهم، ما بقاش مصدق الكلام ده، فيبقى عندهم باد اكسبيرينس. القعده دي هي مهمه قوي، لازم نبقى فاهمين this is the safest place on earth for any child to sit on the lap of his father or mother. So please, that's very important thing. Again, concentrate on the entrance of the child. You guide the parents that please, you are the one to sit. Some parents get the child and put him on the examining chair. Please don't do that. Just guide the parent. Please, you sit and put the child on your lap, so the child is coming easy and feel safe. So that's very important. So لو سمحتوا خليكم في البوزيشن ده. دايما تخلي الطفل اللي هو صغير ده يقعد على حجر بابا او مامته، هو ده اللي بيخليه حاسس بالامان. لكن ان هو يجي ساعات يجوا يحطوا الولد على طول على اوضه الكشف، على كرسي الكشف، وتلاقي صريخ بقى صويت. طيب سكول ايج طبعا الموضوع بقى اسهل. التين ايجر بقى قصه ثانيه. التين ايجر بقى ساعات بيبقى صعب شويه. اول حاجه مثلا من اول فوق بقى 13 14 سنه بقى وانت طالع، يعني مبدئيا كده هو متضرر منك وهو داخل شايف مكتوب على اليافطه عياده اطفال، يعني ده مبدئيا كده هو بيبقى مخنوق منك، يعني الاطفال ايه يا عم، وصوته بقى كبير وراجل ودقنه مش مطلعها شويه وشاربه ومتقله وبتاع، فبالنسبه له الكلام ده مزعج شويه. فالتين ايجر you have to deal with him as really a very grown man. بلاش حكايه بقى تعالى يا حبيبي واعمل، لا، التين ايجر ده لازم تتعامل ان هو راجل، اهلا بحضرتك، ازيك، في ايه اللي مضايقك. وبعدين في الاطفال احنا بنبدا بالبيرنتس نسالهم اخبارهم ايه. لا، التين ايجر ابدا بيه هو الاول. هو انت لازم يبقى فاهم ان انت مش جاي تابع لباباه ومامته وتتعامل معامله الاطفال، لا، ابدا بيه هو وقول له ايه المشكله. So in teenaging, especially in teenaging, start with the child or the teenager guy. What's the problem with you? What's the problem? What do you complain of? And so on. This picture says a lot. This picture says a lot. You can see many things. First thing, the child has this balloon. We have get it to the child in the beginning, so you're like making a communication with her. The smile, this nice smile. So trying to be more friendly with the child. She is sitting again with the magic way of sitting on the lap of her father, and there is no, no barrier between me and her. So this picture has a lot to say, and I'm bringing here a target to follow. فالصوره دي لطيفه وجميله وحلوه بتوضح حاجات كتير، وبتوضح المنظر اللي شايفينه. والناس اللي عندها صعوبه في فهم الانجليش يعني ممكن، يعني اظن الصوره بتتكلم من غير اي لغه او من غير اي حاجه، ان احنا الحفاظ على الابتسامه الجميله وهي ماسكه في ايديها حاجه من ايديها بالونه فكنها، فالطفل قاعده هادي. دي كانت بتصرخ صريخ فظيع في الاول. طيب برضه uncooperative baby this way, there's no problem to let the father carry on the child. كتير قوي بيحصل كده. ده الاب وقف وحط الطفل على كتفه، وانا لافف ورا الاب وباكزامن عادي جدا، كتير جدا examining يعني while the parents is standing up. Many times I do this. The child gets calm، يعني الاب شايله على كتفه ومرتاح ومبسوط. هذا بيفرق كتير جدا. ده اكشف براحتك. يعني ريتينوسكوبي كتير، عملت ريتينوسكوبي في البوزيشن، الطفل بيصرخ وبيدا، خلاص شيله حطه على كتفك ارفعه وانا هلف من ورا وانا هعمل ريتينوسكوبي، هبص على ايه الليجن اللي عنده وبسهوله اقدر اخد الداتا. فده يعني الملخص في الموضوع ده، ان انت تحاول على قد ما تقدر يعني تحترم مخاوف الطفل. كل الاطفال على مستوى العالم بيخافوا من نفس الحاجات، وحاجات معينه بتحبوه بتعجبهم، حاجات ثابته تقريبا بتضايقهم، بالذات الصغيرين قوي. طبعا كل ما بيكبر بتبتدي الانفيرمنتال فاكتورز بتتغير من بلد لبلد بقى بعد كده. برضه دي حاجه لطيفه، الاتراكشن، الكرتونز. يعني دي فروم ماي اون كلينيك. شايفين الكرتون ده توم جيري، دايما في كرتون موجود بتخلي الطفل يركز فيها. زي ما شايفين كده الطفل مركز عليه وانا بعمل كفر ان كفر وبقيس زاويه الاسترابيزمس بمنتهى الحريه. فبرضه الحاجات دي مهمه وبتاتراكت الاتنشن بشكل كبير. طبعا اول حاجه بنعملها هيستوري تيكينج زي ما احنا عارفين طبعا. يبقى احنا الدخله الاولانيه دي، ده اللي يفرق بيننا وبين اي حاجه ثانيه. انت بتكشف على الطفل وبتكشف على اي حد ثاني، الدخله بتاعته وازاي تفكه لو هو انكوبتيف والكلام ده. بعد كده هنبدا طبعا اول حاجه الهيستوري. انا مش هستفيض في الهيستوري، انا بحاول زي ما عنوان المحاضره دي تيبس اند تريكس، يعني هحاول اديك شويه نصايح من خبره يعني مش قليله شويه يعني في التعامل مع الاطفال. فاكتر من ان انا ادي يعني معلومات كثيره موجوده في الكتب يعني. فهو the point in the history taking is from whom you take the history. Definitely you will take it from the parents of course. Don't forget to ask the child. احنا قلنا في التينيجر تبدا بيه. في التشايلد بقى اللي هو يقدر يتكلم مثلا 3 4 سنين، طبعا سكول ايج طبعا موجود. ده لازم حتى بعد ما تاخد الهيستوري من البيرنتس you have to still ask the child. Many times the words of the child is very important. Many times the parents history is guided. Many times. كتير جدا من الاهل جايين عشان يقولوا الولد ده عنده مشكله، يقولوا له بطل يبص على الموبايل، بطل تلعب في الايباد، الولد عينه بتوجعه ومصدع وبيدوخ وبيقع. كل ده عشان تقول عايزين في الاخر يطلعوا من الكشف عشان انا بقول لهم الولد ده فعلا المفروض اقول له المفروض يبطل موبايل، يبطل الايباد. لا، فلو سمحتوا لازم بعد ما اسمع الاهل with all respect to the history from the parents I have to listen myself what's really concerning the child as much as I can. طيب بقيه الحاجات بقى مش هستفيد فيها. الكومبلين طبعا بالتفصيل في الاطفال بانك بتيك سام تايم ان هيستوري بريزنت illness past history of previous treatment, previous glasses, and so on. I will not proceed for this. This is just classic as much to a certain extent. Okay, before the examination, don't forget to observe. The observation is extremely important. First, to check how cooperative is the child as we have been talking. حاجة الثانية بقى في حاجات في الobservation لو وقعت منك هتقع فاين كبيرة زي مثلا الشاب ده شاب كبير شوية ده طفل كبير شوية ان انت تاخد بالك ان الولد ده عنده facial asymmetry مثلا. فالاوبزرفيشن بسرعه لو ساعات بتبقى مشغول قوي بالكوبريشن ومشغول ان انت تلحق تقعد الطفل وتكشف عليه لكن ما تاخدش بالنا من شويه حاجات بسيطه في الاوبزرفيشن لازم ناخد بالنا منها. الشايلد ده جاي يكشف ان انا make sure that the father has almost the same problem with the child, so I'm dealing with something that's familial. So observing the parents is very important also. Many times observing the parents, like a child coming with leukocoria and you can see the parents having nystagmus, so you have there's something familiar is going on. So observing the parents actually is important. Of course, when you suspect something like child abuse or this is very important to when you suspect this to act accordingly. So not just red eye. When you have a suspicion of having a child abuse, we have to make sure of this. Sometimes many times we are the first to diagnose child abuse. Then, if the child has the glasses, the first thing is that you take off the glasses, of course. Taking off the glasses. Who will take off the glasses? Please avoid that you will be the one to take the glasses forcibly from the child. Please try to avoid this. It's not you, it's the child himself. Ask the child, please show me your glasses, show me your nice glasses. If the child is very uncooperative and he cannot take off the glasses, very young for this, ask the parents to take off the glasses and bring it to you. Many children, even if they don't like glasses, they don't like you to take off their own glasses. Okay? يعني بيقول لك بقى لا ده هياخد مني حاجه حتى لو هو ما بيحبهاش ده هتاخد مني حاجه بتاعتي وحتى even if the parents gave you the glasses assure the child I will look at it and bring it back to you. Okay, so make him calm for this. When I take the glasses in my hands, I have to check it and not just taking. You have to double check the glasses in every visit. That's extremely important in kids. How many times you find the glasses have a lot of error? That's very important, especially if the child has failure to comply with such glasses. I have to double check the refraction in the file. Double check what has been written or been done in the last visit. The numbers written in the prescription, I have to double check it. The lens power, I have to check with the lens meter how many times you find the power is different than what you have been prescribed. Or you find that they have changed the glasses with someone else during this visit. I didn't tell you. So in every kid with the glasses, you have to measure the power of the glass, know exactly what the child is wearing now, because you will make a decision about about his vision or his angle of deviation if he has strabismus with his own glasses that he's really wearing now, not what you have been prescribed last visit. Okay, and the axis, you have to check if the axis is okay or not. Especially that sometimes we see such kind of frames. This creates the circular frame. I don't like it at all. The purely circular frames, because the purely circular frames sometimes with the low quality glasses, the glass itself, the lens can rotate easily, and they don't notice this because it's just circular. So if you have a child with a cylinder, just the only instruction you give them for the glasses is please don't choose the complete circle because it may rotate and the axis can change without they know. One of even more worse than this, sometimes when both lenses get off the frame and the mother come and she puts it again, put them both in the glasses, many times they confuse right and left glasses. How many times this happened? I find a child and I'm going to measure the glasses in the lens meter. I found the right prescription in the left and vice versa. So you have to double check this, and I always instruct the parents that if both lenses has been removed from the frame, you are not the one to take them back. You have to get the glass, the frame, and the lenses and the prescription, and go to the optician to put them on to make sure that right and left and proper axis and so on. And of course, inspect the glasses. Sometimes you have obvious nonsense things, like this glass with bifocal. The type of bifocal is not what has been prescribed. And interestingly, the reading part was in one of them. So you have to inspect the glass itself. That's very important tip in kids, because remember, in kids, they don't usually complain. or even if they complain they don't like glasses, and you feel you are giving them the right one, you may ignore their complaint sometimes. And this is the very important for him, because he has amblyopia, he has to wear the glasses. So either they don't complain, or even if they complain, you may find this is normal for such case to complain a bit about the glasses. So you really have to make sure that this glasses is really right. Take some time for this. Okay, that's very important for them. So the next step, we have a question here, interesting. Okay, now you start the examination. That's the next time. You start the next step. You start your examination. The question is, I have a question like this: the most important single examination test for a preschool child is, and I would like you to write down on the chat. Please write down on the chat. Okay. Let me read what you have typed in the chat. Cover test, visual acuity. Interesting. More and more answers, please. Interesting. I meant to see all these types of chat. Wow. Maybe it happened as I expected. My kids come. Okay, let me ask them the question. Come, Ibrahim and Ismail, my kids. What's the most single examination test in a preschool child? Is
red reflection.
What?
Red reflection.
Red reflex?
Red reflection.
Okay, tell them.
Red reflection.
Red reflex. Interesting. Thank you. The red reflex. Again, tell them, please.
Red reflex.
Thank you. This for you, Ismail. This for you, Ibrahim. Bye-bye. Close the door, please. Thank you. So the most important single examination test in a preschool child is red reflex. As you said, it's known for all kids. The red reflex is very important. A lot has been said already. Red reflex, red reflex. I agree with you. And we will show this for you next. So the next is ocular examination. Now let's shift to the ocular examination. Show a toy for a child when you do examine with them. The red reflex, again, as you mentioned, and you listen to Ibrahim and Ismail, red reflex is very important. And we'll speak about the red reflex in details, why I choose it as the most single examination test. Of course, checking the vision, doing orthoptic evaluation, anterior segment examination, posterior segment examination, and refraction. Fixating in a toy, that's the most powerful tool you have in the clinic, believe me. The most powerful tool, you have different types of toys, some with light, some with noise. We need sometimes some with light, we need sometimes some with noise, we need sometimes with light and nothing, with no voice, just to make sure how the child is following. So that's very important. And remember the rule that say one toy means one look. One toy, one look. So you have to get more than one toy, because I mean, if you have only one toy, by the time the child gets bored of this toy. And there is one application on the mobile, interesting, and has some targets like this, this butterfly and making noise, moving, and these things, crocodile. So that's the kind of toy. Let's talk about the red reflex, which we mentioned that I believe is the most important. Give you a lot of data that you cannot get by a single test. For example, if you see the appearance up, bright reflex, equal reflexes, everything is fine. So you have a lot of conclusions that you have a clear media. That's a conclusion. Aligned eyes. You don't have a significant refractive error because of this bright light reflex. Even without dilatation, I'm talking again. We haven't dilated the child yet. Even without dilatation, just have a look with reflex by diet or by retinoscopy, by the retinoscope or by the direct ophthalmoscope. That's very, very helpful. It gives you a lot of idea. If you have a dim reflex, so we have possibilities, like, for example, high refractive error or misalignment. If you remember in the past lecture about cover and cover test, If you have a misaligned eye, the misaligned eye will be, remember? Let me ask, the misaligned eye will be the brighter one, yes or no? Let me see the comments here. Yes or no? Put in red or green. The brighter is the misaligned eye, or the reverse. Say yes or no. The brighter is yes, no, yes, no. No, please don't type yes or no. Type green, right or wrong. The green and red. The majority saying yes. The majority clicking on yes. Yeah, that's great. Yes, yes, the deviated eye is the brighter. That's called Bruckner reflex. And also, if you have a white reflex, they have abnormality, of course, as you may know, the white reflex can include all the differential diagnosis of leukocoria, including cataract, including retinoblastoma, including any kind of colobomas, whatever. So all the differential diagnosis of leukocoria can be there if we have a light reflex. Also, we can easily detect any abnormalities in the iris and the pupil. This child has coloboma. So the other reflex, you got an enormous number of information just from one test. Also the transillumination, of course. Many kids of ocular albinism, you cannot detect it unless checking the transillumination. The ocular albinism, the child is from outside is very fine, has a black hair, everything, but just one examination, one of the most helpful things, besides the nystagmus, and you don't know what's the cause of this nystagmus, the transillumination can help a lot. So again, the red reflex is extremely, extremely, extremely important. Then the next step is checking the vision. The checking vision in adults is completely different than checking vision in children, completely different. This is a very nice diagram, and I put it in my clinic, and it's very helpful even in describing to the parents the development of the visual system. Like in the beginning, when they are newborn, they don't see the objects very clearly. And as soon as they get bigger and bigger, they start to see things clear, just in case that everything is going fine, there's no media opacity, there's no misalignment. So that's very helpful. So you have to know that at birth, the vision is not that good at all, and it starts to develop with time. If you are happy with exact milestones, you can screenshot this table. That in the first 2 months, we can expect pupil response, just a sporadic fix and follow, some jerk eye movements. By up to 2 months and more, they can start doing expressing what's called central fixation, central following, some smooth eye movements, and so on when they go older and older. So the question is how to check the vision in children, how to take an idea about vision in pre-verbal, especially for children. The very famous thing is the occlusion of one eye. If we occlude one eye and the child resists, but I have to occlude the other eye and see what happens. Because if the child cries when I close the right eye and then cries when I cover the left eye, so he's just crying because I'm covering his face. So, I mean, the difference, when I cover one eye, he's happy. When I cover the other eye, he's really crying and really resisting. This is what's called inclusion of one eye. And the fixation, we have a fixation. We check how this fixation of the child, like the famous CSM, central, steady, and maintain. I mean, the child his fixation is fine, it's central, it's steady, and can maintain fixation on objects. And again, use a toy or something to attract the attention to check what's called fixing and following, how the child is following. There's some fixation tests also that can help. Simply cover and cover test. If I cover one eye, if a patient has deviation, for example, and I cover one eye and I find the other eye take alignment, take a movement to concentrate on a target, this means that this eye is really can see. If I'm covering and the one eye and the child is not following, so this indicates a very, very poor vision. If I have a child that doesn't have strabismus, we do use simply what's called vertical prism deviation test. It's a simple thing. When you put a vertical prism, we expect that the image in front of the eye will move towards the apex. When the image in front of this eye will move, he should move his eye accordingly. So if this doesn't happen, it means that the child is not seeing. So if we have a shift while we put prism, this means the child can see by this eye the target, because he is interested in that the target has moved and is trying to follow it. But if I put it, if I not change, so this means that he's not seeing with this eye. Why we use a vertical prism? Because if it was a horizontal, we have a fusion, high fusion potential. But in the vertical, the fusion potential is very small. So just 4 or 6 prism diopter can cause a significant change. One more way interesting, the preferential looking. That's very helpful. The preferential looking, like Teller's acuity card. Teller's acuity card can be checked easy for a child like as young as 6 months and up to 3 years, or of course, or even more. Simply, the preferential looking based upon the child likes the stripes rather than a plane. الطفل بيحب الحاجة المخططة عن حاجة سادة خالص. يحب يبص بعينه على الحاجة المخططة. These are the cards of the tiller. They have stripes at one end only. You can see the picture. This is me. I'm holding one of these tiller cards, and there is a small hole in the center. From this hole, I look through this hole. Why this hole? Because I have to cover my face, because the face is an attractive thing for the child. So the child will keep looking on my face and not looking at the card. So as you can see down, here are all the cards, starting from the bigger one to the smallest, to the smaller ones. And then I get one of them and let the child look, and through this hole, I look to the child's face and see where he looks. If the child looks to the left, so he's really following the stripes, so he's appreciating the stripes, so he can see them. Okay, if the child just keep roaming, so he cannot see it. And they get the next one. Of course, they are haphazardly, some right, some to the left, haphazardly. And I get smaller and smaller and smaller until one card that he cannot concentrate on which is which with the stripes, which right or left. Then I record the previous one as this the maximum that he could see. And then I have numbers in the back of the cards. This number, I put it in this nice graph. This is a graph. You look at the down line is the age in months, 6 months, 12 months, 18 months, 24 months, and so on. And up is the numbers written on the cards, which I put according to the distance between me and the child. As you can see here, this is how many centimeters I am between me and the child. For example, this 38, this 56 centimeters, whatever. So I got the number, I put it, say I'm 56 centimeters from the child, so I put it in this line. Okay, I know the number, and then I get according to the age and put a mark. When I put a mark, I compare it with the normal. What's the curve that you see is the normal. The dotted one is unilateral. I mean, each eye should be seen within this dotted area. But if I'm checking both eyes, so it is the area between the straight lines here and here. It's very important. It's very, very, very good that you can see here from 0 up to 36 months, which is 3 years, how the development of the vision normally happens. So that's very important and very nice in instructing the parents how their amblyopia therapy is getting good, better or worse. For example, if a child got this number here, like 3.7, while he was 6 months, and then when he was 2 years, it's the same, it's 36. So the same thing. It seems that the child is stable. No, he's not stable. They should improve by this age, by 24 months, by two years. So that's very important in comparing the vision of this child in comparison to the normal. اتمنى يكون مفهوم الجراف ده. الحقيقه تيلر يعني مفيد جدا وظريف والحقيقه لطيف جدا ومفيد قوي. The same idea with what's called layer hiding height. It's the same thing. حاجات كده عامله زي المضارب الراكت. One plan and one with stripes. And again, one with stripes, broad stripes, and then smaller, and it's the same thing. I put them in front of the child and then see to which direction he's looking. It's the same idea. Also, the Cardiff is the same idea. Have a picture on the one corner and see the child looking at one corner. When child reach about 2 years, he can use what we call naming picture. He can see naming picture. Can do what's called a matching test. Matching like he has a paper in his hand, and then show what you showed. You just say that what I can see is exactly like this, and so. Then usually at age 3, they can name pictures by age of 3 years, like a horse, car, and so on. Usually by age of 3 years. Before the age of 4 years, usually they can say the directions. You can use the numbers, you can use the alphabet, but usually they can see the E, the regular symbols by age of 4 years, sometimes even before, according to the how child is quite small. It's usually around the age of 4 years you can start doing this up and down, right and left, and so on. Let's have some, but before going to any more tips in the examination, I want to have a break and receive some questions. Let me open the chat and let's read if we have any questions on the previous part. Any questions to be written in the chat? Let me see the questions here. Is the red reflex and retinoscopic examination the same? The red reflex just called the Bruckner report. Okay. Someone asking about the tiller acuity charts again. Okay. Dr. Khalid asking about the tiller. Okay, let's get back for the tiller. For the tiller, you have these cards. You put it on your lap. The child is there, and then you get the card and rotate it. You are looking from the center by the very small center. It looks toward the stripes, like for this case, to my right hand. This means the child can apply the stripes. Then you look and get the next one, which is smaller. It's not. It could be the same side on the right, or could be the opposite side. It should be random. And then see the child how he follows. So until there is one card, smaller, 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 then one card, he cannot follow which direction. He's just moving his eyes. At that moment, you take the number written in the card or the previous one, and then you put it on the graph. ماشي يا دكتور خالد تمام. وقتها يعني somehow Arabic بناخد الرقم بقى اللي طلع معانا ده. انا برفع دي وابص من النص وبشوفه بيتحرك ازاي. اتحرك في اتجاه معين ناحيه السترايبس يبقى كده هو شايفها. اجيب اللي بعدها في اتجاه يبقى شايف لغايه ما يجي واحده لا احس ان هو مش مركز فيها اخد الرقم اللي قبلها واحطه على الجراف. لما اجي احطه على الجراف ادي تحت الايدج خلاص انا عرفت الشايد ده مثلا عنده 12 شهر مثلا سنه. يبقى انا اشوف هنا هو جاب الرقم كام. جاب الكارت رقم 13 وانا على مساله انا كنت بعمل تيست على 65 سم. يبقى اجي هنا وامشي بالعرض واحط هنا عند 12 يبقى دي الرقم دي الرايت اي. بعمل نفس الكلام في الليفت اي او بوث ايز بقارنها بالنون. اوكي. كل ايام عندين سوا you can do usually we do the three right eye alone left eye alone and then both together. Yes, every card as in the front a number. Okay. Oops. So let's move. Let's move for more tips for the child examination, and then we'll take more questions later on. As one important tip with the child, I always teach my residents that you have to be systematic. Systematic in history, and in the examination, you have to be systematic on your examination. I mean, when you try to examine, you have this observation, you observe the appearance, and then you start with the eyelash, eyelid, conjunctiva, cornea, the FLIR, the epithelium, stroma, and you have the anterior chamber, and so on. You have to be systematic on your examination and your history taking. Yet, sometimes in children, especially uncooperative children, you don't have the luxury of wasting time in things that's not the most important in this child. So it's a kind of what's the order that you start with. The main idea, start with the less invasive examination first. دي قاعده عامه يا جماعه لو سمحتوا. ابدا انا ما عنديش، ممكن انا ابدا اكشف في حاجات ما هياش قيمه قوي في العيان ده، وفي الاخر افقد الكوبريشن بتاعه وابتدي يصرخ كتير وفقدت اهم حاجه. يبقى انا لازم انشن على اهم حاجه. كده history taking is very important. So I know in the examination what's the most important thing in the examination that I need. Okay, so I have the most important 2 or 3 points I had to check, and I choose from them what is less invasive to start with. Again, you want to delay the point where the child turn to be uncooperative as much as you can. حاول تاخر اللحظه دي، اللحظه اللي هيبقى طبعا لو شاطر طول القعده ما يبقى مبسوط ده يبقى كويس، انما تحاول تاخر قد ما تقدر اللحظه اللي هيبقى فيها مش متعود. فstart with the less invasive. For example, after dilatation, for example, انا عايز اعمل ايه؟ عايز اعمل اوتوريف وعايز اعمل ريتينوسكوبي وعايز اشوف فندس. Okay? When you think which is less invasive, which is more invasive, the retinoscopy is less invasive. You can do this 1 meter, even 1.5 meters away. So that's less invasive to do retinoscopy first. Then you can do the autoref. Put the child in autoref. You use the autoref, you get closer to the child. And at the end, please leave the fundus examination till the end, because usually this is the most thing that's really that bothers the child, the fundus examination. Most of the kids, they don't like the bright light and these things. So you can leave the fundus examination till the end. Try to do this. I think this could be quite helpful. So try to lessen to delay the fundus at the end. So you choose the less invasive first and then the more invasive. And again, if you have to choose the most important first. I'll give you an example. If I have a child with strabismus, patient with esotropia, and it is left esotropia. A child with left esotropia and is strongly fixing with the right. He doesn't see with the left. And I'm seeing the fundus. Which eye is most important for me to examine first? Of course, it's the left. If I am usually I'm systematic, I'm examining the right eye before the left eye. But if I started examining the right eye for this child, it may get to be uncomfortable and may be hard for me to see the fundus of the left eye, which is more important. More common that if I have left eye strongly deviated and is not fixing with it, so if I have a pathology in the fundus, it will be in the left eye. It's very unusual to have a situation like this and the pathology in the other eye. So start with the more amblyopic eye, start with the deviated eye, because if there is a pathology in the fundus, mostly it will be in this eye. Start with this. One more interesting point, it's not only because of this, because the amblyopic eye, the discomfort from the light is much less because of the contrast for them is less. So many times when you examine the amblyopic eye, they can tolerate it. But when you go for the normal eye, they start to have a really annoyed. So start with the deviated eye. This is for example. So start with the most important and the most important point to check for. Okay. And of course, some tips that in doing retinoscopy during fundus, the alignment is extremely important and to be on the same level as we will show later on. Again, the red reflex. So use either direct ophthalmoscope or retinoscope to check for the red reflex. As we mentioned, this is the most important thing. Then it's very helpful in many things. Also, you can do Hirschberg test, the red reflex, the cornea, seeing the alignment. And as we mentioned in the previous lecture about the motility assessment, this is a very rough method, but still you can just take an idea. And you check the pupils, as we mentioned, for the symmetry of the pupil. If anisocoria will detect it, and assess any obvious abnormalities of the eyelid and the orbit. So really, it's helpful. And you can even check the movement with the light. It's accepted to check the movements with the light. We said this also in the previous time. You cannot do cover test with light, but you can do motility with light. And if it is retinoscopy and not direct, you have the extra advantage that with retinoscopy, you can also have an idea about the dry refraction. It can help you. Okay, so you can do marvelous things with the retinoscopy. And I have a very smart question. I had a very smart question from one of the here asking about red reflex or whether with retinoscopy you mean. So again, red reflex with retinoscopy is very helpful. Then the anterior segment examination. Okay, so after doing this red reflex, we go for the anterior segment examination. You can do it roughly by the direct ophthalmoscope, but of course, nothing can replace the clamp. slit lamp is very extremely important. If the child is old enough to sit on a normal slit lamp, that's fine. If it's smaller than this, you will need to use a handheld slit lamp. Like this. This is mine, by the way, but many years ago. So you can use it with, as you can see, with this portable slit lamp. It's very helpful to see the details. But unfortunately, in the era of COVID-19, again, this is very close for this. So in the era of COVID-19, I'm using some shields to help in this very approximation between me and the child. Like this. If you can see, I put the shield here. So making a quiet barrier between me and the child during examination. So still, even with the portable slit lamp, you can use some. I know that this is very famous sheet for the regular slit lamp, but you can use it and put it on the portable slit lamp, whatever the type. This on the left side is a koa, and the right side it's another one, like the Shinnefer one. And stay safe, please. Now another question for you. Again, use yes. Click on red or green. Yes or no. Someone asking about the dilating drops. Now we will start cycloplegic eye drops for 3 days. We talked about in the very first lecture. The very first lecture was about prescribing glasses in children. Again, choose yes or no. Do we really need, for proper refraction, you need cyclopentolate 3? The majority saying no. 35, 36. Only 2 said yes. Approaching 40 now, more than this. Okay. The majority saying no, we don't have. Why we don't need to have? Because simply as I think I passed by this in the lecture of prescribing glasses, but I have to repeat this when we're dealing with children, because dilating children, that's extremely important to have a dilated and cycloplegic testing. That's very important. So I have to know about how to dilate a child, how to detect cycloplegic refraction for him or her. For example, if you can see this table, these are the different dilating drops. The first one is the phenylephrine. And you can see here the mydriatic effect and then the cycloplegic effect. The phenylephrine has a marvelous mydriatic effect, but it has nothing to do with cycloplegia. It doesn't have any effect on the cycloplegia. So it can dilate the pupil, but it doesn't give any cycloplegia. So it's not helpful at all in doing cycloplegic refraction. The tropicamide, which is the midracil, which is the most famous one, usually we use 1%. We can keep the 0.5%. We use it for very young kids, like below 6 months. We can use we should use less than 1.1%, like the 0.5% concentration. Neglect the mydriatic effect. Now the cycloplegic effect of the tropicamide. The cycloplegic effect, the maximum, I hope you can see it, 30 minutes after installation of tropicamide. And the recovery time is from 2 to 6 hours, which means if I put, if I do cycloplegic, I want to have the cycloplegic refraction of the child and I use tropicamide, after 30 minutes, I expect that the cycloplegic effect of the midracil will fade down. And after 2 hours, for example, if I have a busy clinic and a child waits for 2 cycloplegic effect of the midracil has disappeared, even completely disappeared. Although the mydriatic effect can last, but still the cycloplegic effect is not that enough. So again, if I decided to do cycloplegic refraction for a child with midracil, with tropicamide, I have to be strictly seeing the child after 30 minutes of his last drops. Again, 2 to 3 times or whatever, but I have to be strict in time in 30 minutes. That's very crucial. That's why it's not commonly used as cycloplegic agent, because the range is so tight. But for the cyclopentolate, as you can see, the cycloplegic effect is from 25 minutes up to 75 minutes, the peak. 25 to 75 minutes, so up to more than an hour and 15 minutes. And it lasts for 6 hours up to 24 hours. That's why it's very convenient. That's why most of us are using cyclopentolate in checking the cycloplegic refraction of children. It's very convenient. If I'm seeing the child after 45 minutes, after 1 hour, still I am in the peak, okay? So again, the cyclopentolate, that's why we usually say, but the question here is, the maximum effect is about 25 to 75. It's the So if I'm going to prescribe cyclopentary for 3 days, the drop that has been taken more than 24 hours has completely fade down. So, okay, so that's why there's no rule of giving cyclopentary for 3 days. But the atropine is a different story. The atropine, its maximum cycloplegic effect from 60 minutes to 180 minutes. I mean, from 1 hour to 3 hours. That's why we are not using atropine in office. I'm not giving the child the drops and wait for 3 hours. And again, it has been told that there's a cumulative effect for atropine. So it's recommended to have it 1 or 2 or 3 days. The cumulative effect adds really to the atropine. And the recovery time for encyclopedia from 3 to 12 days. The Mediatic effect, it's famous for 14 days, but this is for Mediatic effect. But for cycloplegic effect, 12 days. So that's why the atropine, if I go to prescribe atropine, yes, this is the one recommended to be on 3 days. And then, but again, you have to instruct the mother that they put drops on the day of examination. Sometimes they put 3 times for 3 days, and on the day of examination, they don't put it. So then they come to you at night in the clinic, it's 24 hours in the last one. So it's not the peak. So you have to make sure that you have to instruct them to keep putting on time, even in the same day of examination. So if you're going to prescribe atropine, yes, it's recommended to be 3 days. But of course, make sure the side effects, you have to instruct them of the side effects. And you have to do, and special care about school age. It's not easy to blur a school age child for 2 weeks. That's not an easy decision. You have to instruct them for this. Now, the question is, I have 2 questions here. Let's have the first question. Before age of 6 years, all kids should have cycloplegic refraction. Please choose yes or no. Before age of 6 years, all kids should have cycloplegic refraction. Please answer yes or no. Not in the chat. Please use yes or no. When you open participants, you will have option of a green one yes and a red one no. So please use this other, not using the chat. Yeah, the vast majority is saying yes. The vast majority, only 4 saying no. More than 60, even more saying yes, and still increasing. Okay, that's great. So before the age of 6 years, all kids should have cycloplegic refraction. Okay. So let's just stop the vote and we'll ask the next question. I will clear all, clear the previous, I'll clear them. The second question. After the age of 6 years, subjective refraction, which means a trial, is enough and there is no need for cycloplegic refraction after the age of 6 years. Yes or no? Again, you don't have to write on the chat. Just choose, click on yes or no in the participant button. The green yes or the red no. After age of 6 years, subjective refraction is enough. You don't have to do cycloplegic refraction. Again, the vast majority is saying no. That's perfect. You're experts now. Okay, that's great. Okay, so this slide is summarizing. The question is, should I do cycloplegic refraction and base this on what I have after cycloplegia, or subjective refraction is more important by doing trials? To summarize, there's no cut point. That's the answer. There's no really cut point. It's like from experience, from collecting different opinions, but most of the pediatric ophthalmologists do the following. I can summarize to you about 3 age groups. The first 6 years, the next 6 years, the third 6 years. Like the first 5 to 6 years, which is called from birth to the whole preschool period. And then the second 6 years, like from 6 to 12, the second 6 years. And the third 6 years, I mean above 12 years of age. And I believe in the first group, and you agreed with me in the poll, that the preschool, the first 5 to 6 years, cycloplegia is very important, and you don't rely on trial. You don't rely much on the trial or subjective refraction. So it is mainly cycloplegia. However, when you go to school age, still, as you mentioned, it's not enough to do subjective. You do subjective refraction, it's okay. You do trial to check the best corrected vision and so on, that's fine. But you have to do cycloplegic refraction too. So you have to do both cycloplegic refraction and the trial. Above age of 12, I cannot say that it's a must to do cycloplegic refraction for every child above 12. I cannot say this. Subjective is the rule. Subjective refraction is the rule. But still, in some cases, we still have a need for cycloplegia. When there's something, I'm not happy, the child didn't come to with 6/6 vision, it's variable. When I do a retinoscopy, I see a significant changes in the refraction. A lot of accommodation is being there. So don't hesitate. If you are in doubt, do cycloplegic refraction. The 12 is not a cut point. Some people feel that up to 10 will be enough. Something up to 14 you should have. But again, cycloplegic refraction should be there. Many times I need cycloplegic refraction for 20 in patients in the 20s or the 30s sometimes even. Okay. So this slide is very important. I recommend you to have a screenshot of it if you would like. No matter this. Now the refraction. We have a lot to speak about in the refraction. Of course, for all of us in every clinic, in every hospital, every center, autoref is the routine, the autorefractometer. Yet, whether regular autoref or a portable autoref, but yet the manual refraction, double check after this autoref is a must. The manual refraction is a must. You have to know this very much. The manual refraction is a must. I like this picture too much. It summarizes a lot. That even if I have in my hand a portable autoref, still I have to do, as you can see in the picture, still I have to do the retinoscopy, the manual retinoscopy. You still have to do this, the manual retinoscopy. What types of portable autoref you have, the most prestigious types of portable autorefs you have even one more, two different types. You can use it, it's helpful, it's nice, but again, the manual refraction is the must. If you choose between, should I buy a retinoscope or an autoref? I will tell you a retinoscope if you are dealing with kids. If you're dealing with adults, it will be hard for you. But when you're dealing with kids, if you want to choose a retinoscope or a portable autoref, choose a retinoscope. Manual refraction is a must. A lot of tips for retinoscopy. I'm not explaining how to do retinoscopy. Of course, it needs not only one lecture, it's several lectures. But some tips for this, if you can, hopefully it will be helpful. What to check before giving drops. ايه اللي تعمله بقى؟ دي نقطة مهمة. قبل ما تدي بقى العيان القطرة دي، هتاخد بالك من ايه؟ ما ننساش بقى حاجات مهمة. اللي هي ايه؟ أول حاجة لازم العيان عنده سترابيزمس، لازم اتشيك الالاينمنت. طب لو ما عندوش، ما هو لازم اتشيك عنده ولا ما عندوش. يعني فاهم قصدي؟ فأنت الأول measure, check the alignment. Do cover and cover. That's the first thing. Check if there is alignment and measure it, because after the patient, you will never on the measurements dilatation, not rely, because the accommodation differs significantly about the angle of deviation. So before giving drops, you have to check the alignment, and if you have an alignment, you have to measure it. And of course, the normal thing in dilatation, even in adults, checking the angle depth just by observation, you have to measure it. Checking the visual acuity, because again, after the drops, the child will be blurred. If you want to check the vision, do it before drops. And check, of course, if he has any drug allergy from drops. That's very important to ask about. That you receive the drops before any side effects happen. Just normal slight raise in pressure in temperature, something very minimal, some flushing, it's okay. But I mean, if it's a rash or really something, I have to take care about this. And again, ask about fever. That's very important. Many times the child is feverish and they don't tell you. So ask this specifically, if the child is feverish, please, if you can avoid and postpone the visit for the visit of the dilating drops. That's much better for this. And it's very important to counsel that after the dilating the drops, there will be difficulty in reading for about 24 hours if you are going to use cyclopentolate. For 24 hours, that's very important, especially in exam times. Sometimes when you face a patient like this and you put drops and after this, I am blurred. Okay, that's normal. But I have an exam tomorrow. I have to study tonight. I have an exam and I have to see it well. It could be a mess. So you have to counsel the parent and the child about the possible, what is expecting to have, and the blurring will fade with time. 24 hours. Very this if the child has to read something and there's an exam tomorrow, you can postpone the dilatation first. Put this in mind, please. That's very important things to put in mind. And of course, you have to counsel with other side effects that's expected and all these things. And one more interesting thing that if you have an opacity like, for example, partial lens opacity, and you have a subluxated lens, I want to see this in comparison to the pupil in the normal size before dilatation. So these are 3 things to double check before giving drops. So يعني I took this in Arabic يعني أنا حكيت إن أنا بالتليفون كده الو عندك كم عيل مستنيني طب وسع لغايه ما اجي لك يا ريت نقلل الحكايه دي يعني وسع العيال كلها لغايه ما اجي دي يا ريت نقلل الحكايه دي. في حاجات كتير قوي المفروض تتشاف قبل التوسيع الحقيقه قبل ما ناخد اي قرار. And during euthanasia, one of the very important tips is the coaxial. Be coaxial. That's extremely important. You have to be coaxial with the patient, because if the patient is not coaxial, you get different numbers. How to catch the fixation of the child? To catch the fixation of the side, there is some things that can be applied on the retinoscope, so you can easily see it. حاجه لطيفه قوي عليها صور جميله ولطيفه وبتاع ممكن تستعملها، او اي حاجه بقى تخليه يستعجل تكلمه، تعمل اصوات ببقك يعني موضوع بقى like this. If you cannot do to the child, it's very hard to be a pediatric ophthalmologist. You have to learn these tips, very important. And one very important thing, if a child has like a candy, this child has a candy ومعاه مصاصه اهو في ايده حلاوه زي ما اخواننا في السعوديه بيقولوا حلاوه، معاه حلاوه ماسكها في ايده. مشهوره جدا. يجي بقى الواد معاه مثلا لعبه او معاه حاجه بياكلها، اول ما الاهل يخشوا هات يا ولد عشان نركز في الكشف، يقوموا شايلين منه اللعبه بتاعته وشايلين منه مصاصه ويلا بقى عشان تكشف، تلاقي الواد بقى فتح في الصريخ. فبرضه هو يعني if the child has a candy, leave it with the child. If the child has a toy or a doll, please keep it with them. By the way, for the dolls, it's a very nice tip that if you have the child with the doll, you can start examining the doll. You ask about the name. What's the name of this doll? Yeah, it's called whatever, Barbie, whatever. Okay, let's see Barbie. Let's see her eyes. You think her eyes are fine, and then you start examining Barbie. This case familiarity, and then you say, oh, Barbie is very good. She's very nice. وهكذا يعني. انت تقول بقى ده شطوره، ده اللعبه اللي معاك دي ده اسمه ايه؟ ده اسمه حسين. حسين حلو لطيف جميل، وحسين شاطر وكشف وبقى شاطر. الحاجات دي حقيقه لطيفه وبتفرق وبتسهل لك حاجات كتير يعني. طيب فالصوره دي اهو keep the candy. Keep the candy. The child is busy with the candy and you are busy examining the child. Again, keep the child busy. This is one of the important tips. Keep the child busy. For the autoref, regarding the axial, this is an example of the patient. This is the portable autoref. If you can, I'm not sure if you can see the screen well or not. Look at the screen of the autoref. The child has exotropia with eccentric fixation. So this child is not coaxial. When they ask the child to keep fixing the left eye, he is not in the center. It's deviated. So in this case, I put my hand to make the child and follow on the screen where the eyes start to be central, and then I take the measurement. So being coaxial is important for the retinoscopy and even for the autorefraction. One important tip for the autoref. Some people, they say refraction for a child means under anesthesia. I want to speak about this in a moment. But interestingly, even I've seen a lot of patients have been examined under anesthesia and having reports of examination under anesthesia, and you find many times you find wrong numbers. Even there is a print from the autoref. I've been examined under anesthesia and I have this autoref for cycloplegic refraction. Many times there's some mistakes on this. Many times the axis is completely different than the reality. So I have to tell you that in most of the portable autoref has this button. This is very important. It's one of the main difference between a regular autoref, stand autoref, and the portable autoref. The stand autoref, the patient is standing. There is no problem with alignment. It's very rare that a normal adult will tilt his head during doing autoref, and you usually fix the patient, and it's easy. But in children, we have a portable autoref. The child can rotate his head, or you are the one that try to do autoref, and then you rotate the autoref. So the alignment is extremely important. The newest version, by the way, of Retinomax, they have this tilt option, and you can see how many degrees you are tilting. But I mean, the most important, you have to make sure that you are aligned together with the head of the child. You are aligned to take a proper axis. And while you are under general anesthesia, or the patient is sleeping, we are commonly getting from the side of the child, like this. Can you see this? Usually you take it from the side of the child. That is degrees, the perpendicular axis. If I'm straight and the autoref is like this, okay, this is the normal. But if I'm sleeping and the autoref will be from the side, so that's 90 degrees different. So I have to change the axis 90 degrees. It's not transposition, it's changing the axis. So all the autoref, most of the autorefs had this button. This button, when you click it, you will find this appearance of a vertical eye, which means that it automatically will change the axis 90 degrees. So you have to take care of this while you are doing the autoref 90 degrees than normal, especially for the patients under anesthesia. Again, the autoref could be handheld, and again, in the era of COVID-19, I prefer the handheld with the screen, so I can stay away from the child. If you don't have a portable autoref, again, retinoscope is very important. If you are still using autoref, that's a good idea. But I want to tell you that really many kids can still sit on a regular stand autoref. If the child is old enough, they can sit like normal, like adults, like this. Many of the kids can do. If they are old enough, they can do this. If they are smaller, there is one position that is not famous. I don't know why. This position is very famous. It's not famous, but very interesting and very helpful. That asks the child to sit on the step. يعني تقول للطفل قوم اقعد على السلمه، قوم اقف على السلمه قصدي، قوم اقف على السلمه. On, and then you wait or get the chair up or down. The only obstacle that if your unit doesn't turn on unless it is locked, you cannot do this with such type of units. So this position is also nice for younger kids. This age group of children is the one that most of the people doing it while they are on the chair on the knees. يعني كتير قوي, let me say it in Arabic again. يعني كتير قوي الاهل تخش كده يقول لك ايه اقعد على ركبتك كانك بتصلي. كتير قوي بيحصل كده. يطلع الطفل يقعد بركبته ويحط دقنه. يعني ده السن اللي بيعمل كده. انا ما بحبش كده خالص الحقيقه, لانهم بيوسخوا الكرسي الحقيقه. يعني تلاقي يعني برجله كده بيوسخ الكرسي, فمش بحب البوزيشن ده خالص. وطبعا ما تقوليش يقلع الجزمه, لان لما يقلع الجزمه ساعات بتبقى يعني وضع ساعات مش حلو, ساعات بيبقى في ريحه مش حلوه. فالحقيقه انا بحب البوزيشن ده جدا. يعني في الايدج اللي هو ده انا بحب البوزيشن. So I like this better than putting the child on the knee, but you can do this of course. لو انت عندك حد بينظف يعني. One more position is also again helpful, that put the child on the knee of the father or the mother or the parent, and this can give also it's sometimes helpful also for young kids. There's a very interesting picture. My colleague Dr. Zainab, I love this position. The child, as you can see, is hugging the autoref, and it's very nice for very small kids. That's a position that it's not always helpful, but I mean it's very nice and it's interesting. I love this picture. Again, one more tip, and we are very close to conclude the lecture. This position of refraction, this is the child that is sleeping, simply sleeping. I can do retinoscope. I can use portable autoref. By the way, if I use the portable autoref in this position, I don't have to click on that button, because again, it is vertical. You get what I mean? Whether the patient is standing or the patient is sleeping and I am from above, it's the same axis, it's the same 100-degree axis. The point is also only when you get on the side, okay? While sleeping, that's a very important point. Don't forget it. Examination under sleeping. Don't forget this tool. This is a very powerful tool. When you get the child, you start playing and do everything, and then you decide to dilate them and the patient wait outside. I usually give instruction to the parents and of course to my assistant outside, to the nurse outside. They know it's very important. I instruct the parents, if the child get bored and start to sleep, leave him sleeping, please, and get him inside sleeping. You have to encourage them. Many times when the child get bored by the drops and get unhappy, they start to sleep. And when they call him to be examined after dilatation, they just wake him up. Wake, we are going to the doctor. That's the worst scenario. That's the worst scenario I like. A child was sleeping and they just waked him up before examination. That's the worst scenario. The child is not completely sleepy, so I can examine easily, as you see in these pictures. And the other side, he's very sleepy and angry that it can be very hard to play with and to convince him for something. So usually when I give drops, I tell the parents that we put drops. If the child feels uncomfortable or want to sleep, let him sleep and bring him inside while sleeping. Either sleeping or he's fully aware to try to play with it. Okay? I will summarize it in Arabic ان هو في الاخر لما تيجي توسع طفل بتقول لاهله لو زهق وقرر ينام سيبوه ينام ويخش لي نايم. اسوأ حاجه في الدنيا نايم الولد يجي يندهله عشان يخش يلا يلا اصحى الدكتور هيكشف عليك. يخش الولد ده مقريف وبيعيط ونيله. فلا هو نايم انا بكشف عليه براحتي ولا هو مصحصح ومفوق فانا اقعد بقى العب معاه واعمل الحركات بتاعتي عشان اعرف مش البوزيشن الوضع مش اندر ستيبنج تعمل اللي انت عاوزه. فما تنسوش اكزامينشن اندر ستيبنج ده لطيفه وجميله وحاجه ما تنسوهاش. لما اكزامينشن ان انا ادخل الطفل في الريفراكشن اندر انستيزيا ما تستسهلوش الموضوع ده يا جماعه مش بسهوله. ما تستسهلوش القصه دي. مش كل طفل عايز ريفراكشن انيمو عشان انستيزيا. الحقيقه ده ابيوز رهيب. الطفل اللي محتاج ريفراكشن وتشيك اب فاندس نورمالي يشوف السنترال فاندس غالبا ما بحتاجش. شويه الالعاب البسيطه اللي بنعملها ويبص على التارجت بعيد والكلام ده خلاص الدنيا بتمشي كويس. ده اكسبشن الحقيقه. هنيجي لاخر حاجه الفاندس اكزامينشن. الفاندس اكزامينشن بس هو فيه تيب صغيره كده وبتبقى سهله وبتسرع الموضوع جدا. انت اهم حاجه في الفاندس اكزامينشن السنترال فاندس طبعا اللي هي ديسكوب ماك. زي ما انت شايف كده تبقى ذا سيم ليفل with the child what the distance of. بص زي ما شفنا اول حاطط كرتون مثلا حاطط تلفزيون فيه توم جيري او وات ايفر. فالطفل بص على توم جيري وباجي انا 15 degrees temporal. Patient is looking straight and I am 15 degrees temporal. I'm exactly on the optic nerve. You check you have on the optic nerve. Then you get in front of the patient, you are on the macula. That's why it's quite easy. It's quite easy to check the fundus rapidly. So you have to do this rapid. And then you can start with the periphery. If you are examining a patient that the periphery is a must, that's another story. Like patient is suspecting patient with Marfan, you're suspecting peripheral degeneration, you have to do thorough peripheral examination with indentation and these things. This different story. I'm talking about a routine check of fundus. Child with strabismus, I'm checking the fundus as routine. The main thing is the central fundus. And it's very easy to check the fundus, to check the central fundus of the kids without dilatation. Okay, this happens a lot. That's why it's a must to have checking the disc and the macula of every child in your clinic. That's extremely important. Don't miss this. Even without dilatation, if the patient has been dilated before, I don't have to do cycloplegic refraction each visit. Patient came at 1 year and then he came after 3 months. And Dr. Ayman said you have to do cycloplegic refraction. I'm not saying they have to do cycloplegic refraction in each visit, but at least you have it in the record. And after a few years, when you have some changes, the patient's vision is not so good, you can double check the refraction, but it's not, you don't have to do cycloplegic refraction each visit. You don't have to do so. But in every visit, you have to double check the central fundus. If the patient has any kind, how many times I check routinely, checking the fundus, checking the disc, and then find some temporal pallor and send the patient for neurologist, and then order MRI and find an abnormality in the brain. Many times this happens. So routinely you have to check, and again, you can't check the disc and the macula without dilatation in kids. It's very easy with the indirect. Just let them look straight, dim the light, 15 degrees temporal, and then you will easily see the disc of the child. Okay, and use the least light intensity possible. Okay, and if the child is sleeping, keep the child sleeping. And again, start with a more amblyopic eye if you are available. This completely differs than when you are checking a newborns, prematures, for example, or infants. The prematures or infants, there is a completely different story. First, for example, the prematures, you need to examine thoroughly, you need to examine the periphery, you need to do some indentation or actually rotation. So usually we need to use speculum. You have to get this premature speculum in your clinic, and you really need to see the periphery, of course, in such patients. And one more tip is, of course, is how to hold the hands. You can let the parents hold the hand. And this position, I like this position too in the infants, actually. How I can do this? I ask the parent to hug the child. And after hugging the child, خده في حضنك كده، هات الطفل في حضنك، بيبي ده في حضنك، ورجليه تحت، حط رجليه تحت عادي كده، وامسك ايديه الاثنين، امسك ايد الطفل الاثنين، وميل الطفل لقدام زي الصوره اللي انتم شايفينها دي. Okay? So hug the child. The parent hold the hand of the baby, and then get the child lie down, and then you put the child on, like this is the doctor. You put the head on your lap. So you are controlling the situation to a great extent. It's a good point to check the infants from above, from superior. So if the child developed, it's very common for a child to have Bell's phenomena. So when the child goes the Bell's phenomena and the eyes start to elevate, it actually brings the eye towards you, brings the central fundus towards you. So it's a very helpful position. But of course, the wrapping of the infant has a rule. This is how to wrap. This is a perfect way to wrap the child. Wrapping is very important for the newborn, or especially for the premature. It can hold the hand and give some safety and calmness to the newborn. As you can see here, you cover one arm, and then you cover the other arm. Then the child gets calm, and you can easily examine him or her. Again, you can examine the fundus under sleeping. Don't forget it. This is the same child. I did retinoscopy, I did autoref, and then I'm doing fundus examination. And one more tip for the children. You can do again, regardless the patient who I need to do is check the periphery, like the patient suspecting of retinopathy prematurity, patient is suspecting peripheral degeneration. But I mean, as a normal check, just normal checking of the fundus, which has been done to every child, you have to see mainly the central fundus. And if you can try to do the central without touching the face, sometimes is the most irritable thing. I mean, when you can put the lens and you don't touch the face of the child, you can keep him cooperative for longer time. And at the end of the examination, it's good to give the child a gift. That really helps. That really helps. Like a sticker. I like stickers. Sometimes I give candies, as I did with Ibrahim and Ismail. Sometimes I give them candies, but that can sometimes being in trouble in the clinic, being يعني بيوسخوا ساعات العيادة وكده. فالحقيقة stickers is يعني more clean, interesting. So you show the child some stickers and he choose one of them, and whatever he chooses, you said, wow, good choice. That's a good choice for you. So the child get happy, and because again, the most of the children in the pediatric ophthalmology clinic are chronic patients. So you are looking on the next visit. You don't happy of just getting them by force, examine them by force, and then you finish the examination and bye-bye. No, remember, after a few months, you see this child again. So you have to try as much as you can to gain the happiness of the child. Let me tell you one important tip also here. I'll say it in Arabic first and then say it in English. خلي بالكوا بقى، الطفل اللي بيصرخ قوي ده، في عيال بتخش صريخ سويت وبتبقى صعبه جدا. مفيش اي مشكله الحقيقه ان اول فيزيت عباره عن لعب بس، تلعب مع العيال، توري له الكرتون، هو مرعوب لان هو قصه اللي حقنه قبل كده، تعالى هنتصور وهو بحقنه، قال لك ده هيحصل معايا نفس الكلام، هو مستخون الموضوع. فممكن تضطر طبعا لان انت باصه من بعيد وبريد ريفلكس كده زي ما قلنا، مهم تاخد فكره كده ان الدنيا سليمه، مفيش حاجه ايرجنت، يعني الدنيا كويسه وبيتشيك اب بس كده، وانت عايز تشوف الولد براحتك، مفيش اللي قاعد هيلعب كرتون ولعبه وتفتكر وتقول له باي باي وتدي معاه تاني الاهل تعالوا تاني بعد يومين، مش اي مشكله خالص في الموضوع ده على فكره. لو طفل مش متعود اكيد افتكر تاني، انت بتتكلم على واحد هيكون كرونيك بيشنت، واحد هيجي لك كتير كتير كتير. فانت الطفل ده مفيش اي مشكله ان انت تلعب معاه وتديه وتمشيه. الطفل ده شوفه بقى المره الجايه وادعي لي، شوفه المره الجايه وادعي لاخوك ايمن. ليه بقى؟ لان هو فعلا الطفل ده بيصرخ عشان خايف من اللي هيحصل. فلما يخرج من عيادتك ويخرج بره العياده وينزل الشركه بعربيته ويلاقي ان ما حصلوش اي مشكله، مفيش وحش كله، مفيش حقنه اتدبت فيه، هيحس بالامان والدنيا زي الفل. هيجي لك المره الجايه بني ادم تاني خالص يقول لك فين الستيكر اللي اديته لي؟ فين يجي ماوس اللي اديته لي؟ وادعي لاخوك ايمن. I'm summarizing this in English. That, please, if you have a very uncooperative child, it happens, very uncooperative, screaming. Usually the child is just afraid of what will gonna happen to him or to her. A previous experience, we are going outside and then an injection. Okay, so the child has a huge fear of what are going to happen. So just spend some time, as we said, few seconds usually, and you get a trust, and then you start the examination. But if the child keep resisting, keep to be very uncooperative, you can first you check there's nothing emergency, of course, by the red reflex as we mentioned. So if you exclude anything emergency, you just play with the kid, show him cartoons, play with him, show him some toys, and at the end give him a sticker or her a sticker, and then bye, and give them an appointment after a couple of days. When the child comes out, you just get calm. He's really angry, he's really upset, he's really screaming because he's afraid what will gonna happen to him. But if you just get away from your clinic and return home, and he realizes that nothing harmful happened to him, there's no monsters who ate him, no injections, then okay, you feel happy. The next time when he comes, most of the time, not all, most of the time, he will be very cooperative. And we'll ask you about the sticker. What about the sticker they gave me last time? Okay, so put this in mind. Sometimes you can end the whole examination by just giving another appointment. That's okay. That's very acceptable when dealing with kids, instead of checking things by phone, unless you're afraid of something, of course, like something serious. You can start by force if you cannot put him under anesthesia. I'm not saying it's contraindicated. Put him under anesthesia and check what could be serious in this child. And at the end of the clinic, dealing with kids is really wonderful. I love dealing with kids. They are very, very nice creatures. They are always grateful. لا جايب لي ورد مثلا، وحاجات متكرره كتير. الصوره اللي لقيتها قدامي يعني الحاجات دي متكرره كتير، جايبين ورد، جايبين لك لعبه، جايبين لك حاجه تاكلها. يعني الحقيقه دايما التعامل مع الاطفال بيبقى جميل ولطيف وممتع جدا. يعني I enjoy يعني dealing with kids many times. So let's summarize some take-home messages. Child is not just a small adult. Communicate with the child early. Few seconds of playing with kids saves time and gives more data. Respect the child needs, fears, and parent concerns. Red reflex is extremely important, maybe the most important, I believe. Start with less invasive and more important tests before completing your systematic examination. And decrease the demand for examination under anesthesia, and think in examination under sleeping. Now I'll show you something interesting. One clip from a famous Egyptian movie about a doctor dealing with kids. I love it and enjoy it. Just 1 minute, and I think you will enjoy it. I will show it now. There will be a huge high voice. Take care of this, and I love it. This is a simulation of what we see in the pediatric clinic. Enjoy it.
ايه دول الهكسوس؟
يلا يلا
تعالوا هنا. ايوه كده. فين العيان؟
ده سمير.
سمير؟ انا سمير.
مش انت؟ سمير صغير ابني.
ابنك. ويبقى واحد بقى اللي واقفين دول.
ده جوه.
هو لسه في جوه؟ روحوني. تعالى بس. تعالى بس.
في كتير بيفتكروا يعني بيعتبروا pediatric ophthalmologist حاجه زي كده يعني. ثانك يو. وده تايم ان احنا ناخد اسئله. المحاضره خلصت ولا المحاضره خلصت؟ ثانك يو وتويلكم لاي اسئله.
صوت ويتي خالص يا دكتور ايمن مره واحده، مش عارف ليه.
الفيديو ما ظهرش كويس؟
لا انت صوتك ويتي كده مره واحده زياده.
طب المهم الفيديو بتاع سمير غانم.
كان كويس يعني باين.
طيب it's time for questions. Let's receive some questions. I think we have 5 minutes for questions. Dr. Wael?
Yes, we have time, no problem. اللي عايز يسأل يا جماعة يرفع ايده.
You can raise hand. And I'll check.
You were very thorough, obviously. يعني You've answered all the questions from the very beginning from the chat. Well, we have Dr. Khalid.
Okay. Can we enable his mic, please?
دكتور خالد اتفضل.
السلام عليكم، يعطيكم العافيه دكتور وائل ودكتور ايمن.
عليكم السلام يا دكتور خالد، ازي حضرتك؟ انا حاولت اتكلم عربي قد ما اقدر يعني.
لا انا يعني الحمد لله بالانجلش كويس، بس دائما محاضراتكم بالعربي بتكون لطيفه اكثر.
يعني بناخد راحتنا اكتر.
الله يعطيك العافيه دكتور. بس انا حبيت اسال واضيف شغله اذا ممكن. بالنسبه للبوتنج دروب، في اني تريكس لانه الطفل بعد ما نسوي كل اللي حكيت عنه انت، بس تيجي للدروبس حقيقه ات هيرتنج هيم، فبنفقد كل الجهد اللي عملناه بالاول. فانا حبيت اضيف شغله انا قراتها وبسويها في العياده، واشوف اذا ممكن انت تضيف لي شيء ثاني، اللي هي انه نستخدم كلمات كثير حلوه للطفل، انه هذه القطره الصحيه او هذه قطره الابطال للاولاد او قطره الحلوين للبنات، ونخليه يمسك بيده القطره قبل ما نحطها، ونعمل 1 او 2 دروبس على يده ايوه، ونفرجيه انه هي قطره بارده، وكمان بنفس الوقت نعطيه الحقيقه انه فعلا حتحرقك لمده ثواني، بعدين حيروح الاحساس هذا، عشان نكسب ثقته لما بعد الدايليتيشن. كمان تريك ثانيه انه ممكن انت بنهايه الدروبس تعطيه جيفت صغيره. طبعا انا ما احب الكاندي عشان ممكن يخلص من عندك يروح لدكتور الاسنان، ممكن شغلات ثانيه يعني.
لا وبعدين هي حصل، شفت موقف زي كده حصل مع ناس دايابيتكس، وكانت حاجه سهله، كانت حاجه ظريفه وغيره يعني تدي دي اخ والاخوه تاني عنده دايابيتس ما يقدرش ياخدها وبتعمل مشكله.
تمام.
هنا بتوسخ العياده الحقيقه.
وحبيت اضيف شغله، بس احنا بتصادفنا مع كثره العمل بننسى شغله، انه هذا الطفل هو انسان مهم بالحقيقه. انا عندي في بروفيسور كبير دكتور مجدي هزاع، كبير بالسن، لما كنت اشتغل معه اشتغل عمليات BMR لاطفال، حاليا هم اوفثالمولوجيست هذول الاطفال. حقيقه مع كثر الشغل بس حبيت انبه لهي النقطه، لانه بتغيب عنا هي النقطه مع كثره التعامل والستريس اللي بتصيبنا بالعياده. وشكرا جزيلا.
احييك جدا يا دكتور خالد على الاضافه الهائله دي. يعني let me summarize in English برضه for those who couldn't understand in Arabic. Dr. Khaled had mentioned many important things. This first question was about the tips of putting the latent drops and how to, because it's very unpleasant for the children, of course, as we all know. He mentioned one. There are a lot of tips actually to give the latent drops and to have it less troublesome to the children. He mentioned one important tip that we can show him or her the drop and put one drop in the hand. Okay, this is the drop. So it's not just fire; it's just a drop. And telling the child that could be a bit cold. One nice tip that can say that okay, you have the sensation of going to a swimming pool. It will be the same sensation as cold in the beginning, and then it will be fun. Sometimes we can use this. ممكن تقول له كده. ممكن تقول له هي ساعة شوية، هتقول معلش ساعة شوية، لكن خلاص بعد كده زي ما بتنزل حمام السباحة بتبقى حلوة بعد كده. This one also of the tips that we can use. One important tip also, again, Dr. Khaled also mentioned how to respect the children. Yes, again, you have to respect every child and deal with him or her. In dealing with such child, that you can tell him, beside that this could be a code, could be something that after this you will feel some blurring. Sometimes, as Dr. Khaled mentioned, you can say that it's a kind of magic drops and you will enjoy it. Sometimes you see it. But there's one important tip that I have to tell the child first. I mean, not telling the child anything and then hold him by force and give him drops, this is a bad experience. And all the time he feels worried. So it's good to give him like a note. And one important phrase is like this, like tell the child that there will be drops to be put, but don't give him too much time to think. Because in young children, however you encourage, you try to convince them, they can never convince why I should adapt something that can hurt my eyes. It's very hard. So let them know before. This can really marvelously decrease the bad effect of the drops. But don't leave too much time for the child to think and to think how bad it will be. تيب كمان مثلا لطيفة ان احنا نحط بينوكس مثلا او نحط topical anesthesia. This is also one of the tips that we can use topical anesthesia first. It can decrease the stinging and can even decrease the discomfort from the light. A lot of tips actually that has to be can be done. It's great, and of course everyone can be creative for more and more points. Any more questions, please? Okay, one question interesting in the chat. Let me answer it. Chloral hydrate. Do you give chloral hydrate? Of course, you can do this. Of course, you can sedate the child with chloral hydrate. You can do this. I myself don't do it. I believe I cannot do it unless I have a supervision from an anesthesia or a pediatrician. So I'm not doing routine. But of course, you can. Many centers are using it. Of course. Okay. Any more question by audio? Who is raising hands? We have one more doctor raising hand. Doctor, what's phone?
السلام عليكم.
السلام عليكم. Can you please introduce yourself, please?
ازي حضرتك يا دكتور؟ شكرا على المحاضرة الرائعة دي. أنا بس كنت عايزة أسأل سؤال. هو لو طفل جه العيادة والنضارة بتاعته اتكسرت، يعني هو دايما بتيجي أطفال طول نضارته لسه مكسورة، هو كان اوريدي عامل السايكوبليجيك ريفراكشن أو كده، هل كل يعني لازم أعمله سايكوبليجيك ريفراكشن تاني ولا هتصرف معاه ازاي؟
كويس. اوكي. Thank you.
شكرا.
طيب, well, the question is, if the patient came with broken glasses, should I repeat the cycloplegic refraction we did last visit? Again, you don't have to do cycloplegic refraction every visit, of course, but you should have the cycloplegic refraction be in the patient's record. It should be. You don't have to do it every time. When you need to do it, a lot of indications for this. For example, if the patient vision is not improving, the has amblyopia and is not improving, you have to do re-refract. Maybe the old refraction was wrong. If the child is really not happy with the glasses, you can double check the refraction. If everything is fine, you did the cycloplegic refraction a few months ago, and the patient is seeing 6/6 vision, you don't have to do it every time. Okay. خلينا نبص من الشات كده. في الشات اسئله الحقيقه لطيفه برضه.
حد بيسأل على السيريس سايد افكتس اوف سايكلوبنتوليت.
طبعا. اوكي، كلام حلو. هي ممكن نتكلم على السايد افكتس كان موجود في الجدول وعدينا عليه بسرعه كده. I'll give you one important tip. You have to, as I mentioned, you have to counsel the parents about the side effects of the cyclopentolate, like flushing, for example, and again the blaring and so on. And I have to tell them that if the patient developed really significant fever, and you feel the patient is start to be hot, you have to inform us. But there is one rare complication, which is the hallucination in cycloplegic. You have to be aware of this, because though it is rare, but when it happens, it's really a very hard situation to face. I'll tell this in Arabic fastly. موضوع hallucination ده موضوع مهم يا جماعه، ما تاخدوش بهزار. لما بيحصل بتبقى مشكله كبيره جدا جدا جدا، فيها خطوره على روح الطفل. عندكم امثله مثلا اللي انا شفتها في الهالوسينيشن ده. طفل منهم دخل في الهالوسينيشن، بدا يقول كلام مش مظبوط، وبدا يجري ويخبط راسه في الحيط، يخبط راسه في الرخامه، حاجه زي كده. وساعات اطفال كبار مثلا 6-7 سنين، حد كبير اللي هو مش بيبي انت ماسكه، فالحقيقه ده ممكن يبقى خطر جدا، ممكن يرزع دماغه في حاجه، ده ممكن يبقى فيه خطوره على حياته. والاهم من ده الاهل بيبقوا مرعوبين من الموقف اللي حصل ده. فالحقيقه برضو ازاي تتعامل مع الهلوسينيشن بتاع السايكلوبنتوليت رغم ان هو رير، انما لما يحصل لك لا ده عايز كلام بصراحه يعني انا اتكلم فيها شويه. اسمح لي ترويل بدقيقه كده ولا اكتر في الحته دي، لان لما بيحصل انا شفت التعامل معاه الحقيقه الاهل بيبقوا مفزوعين. فمهم قوي الري اشورنس. ده طفل بقى تاخده هو واهله تدخله العياده على طول وتقفل على باب العياده وتتكلم معاه الاهل بالراحه ان دي حاجه بتحصل ودي حاجه مذكوره وشويه وقتها هيروح. اهم حاجه اشور السيفتي بتاع التشايلد. لو مجنون وبيتجنن يعني، سوري انا اسف كده قصدي، يعني بيعمل حركات بيخبط في الحيطه وبيعمل، لا لازم تسكيور ان هو حد ماسكه، حد ماسك ايده، ولغايه ما يعدي الفتره دي، انه هياخد وقت في الموضوع ده لغايه ما الطفل يهدى. ولازم تطمن الاهل ان هي ماتر اوف تايم وهيخف. وده بقى دي من العيانين اللي بكلمهم نمرتي وبكلمني اطمن عليه، لان فعلا بيبقوا مرعوبين حاسين ان الطفل حصل له حاجه. فالحقيقه برضه هالوسينيشن دي من الحاجات البايخه جدا لما بتحصل في السايكلوبنتوليت هالوسينيشن. الحقيقه الصعبه يعني. when English كده summarize it, you have to counsel the parents very thoroughly. You have to bring the child inside, keep the child safe, keep counseling the parents that it will remove, but you have to take I'll tell the parents كده keep the child in your hand while you are moving away from the clinic. تاني كده ممكن الوقت كده عشان مش عايزين نأخر عليكم واكتر من كده. انا شايف لسه في اسئله.
محاضره عظيمه يا دكتور ايمن والله بصراحه.
ربنا يرزقك والله يعني. وانا طبعا يعني عايز اشكرك جدا. ويا جماعه انتوا مش عارفين ترويال بيعمل مجهود ازاي في المحاضرات دي الحقيقه. يعني على يدي صراحه. very very huge effort. هو كويس وهو تعبان وهو بيعمل مجهود رهيب very huge effort عشان يعمل المحاضرات دي. الحقيقه thank you very much to ترويال. very very huge effort. ان شاء الله في ميزان حسناتك ان شاء الله يعني. كل حد اتعلم كلمه من المحاضرات اللي انت ساعدت فيها الحقيقه.
Thank you. I appreciate it.
Thank you very much. I'm sorry for any question that I didn't answer. بس فعلا انا مش عايز اطول عليكم، مش بحب اطول قوي يعني في المحاضره قد ما اقدر. فيعني اتمنى كده ان شاء الله تبقى مفيده. واحنا سجلنا المحاضره دي وان شاء الله شويه وهينزل التسجيل بتاعها. لما انزلها على صفحتي برضو لو حد عايز يسالها اهلا وسهلا نحطها في الكومنتس يعني.
تمام. بنفكر الناس بس ان احنا يوم الاثنين باذن الله عندنا دكتور نيكولاس فولت الchairman of the ophthalmology department في Northwestern University. He's a neuro-ophthalmologist. هيكلمنا على optic neuritis and papilledema, modern thinking and modern imaging. high profile international speaker. احنا جايبينه مخصوص علشان يبقى مدينا سيشن neuro-ophthalmology قوية. اعتقد يعني حتى هذه اللحظه ان دي هتكون اخر سيشن لينا في رمضان. بعد كده هنتوقف العشرة الاواخر ونتوقف العيد، ناخد بريك شويه كده. احنا تعبنا وانتوا تعبتوا معانا والويبينارز كترت قوي، فربنا يسهل. بالنسبه للهبه كل الناس عماله تسال عليها، هنتفق عليها ونبلغكم بيها.
You have to take the credit. You were the first. يعني we're the first to start series of webinars.
ربنا يخليك.
الحمد
لله ان هي يعني الناس كلها يعني انيشيتيف كويس، الناس كلها يعني تستفيد يعني. الحمد لله. شكرا يا دكتور ايمن، رائع كالعاده، ونراكم جميعا يوم الاثنين باذن الله.
Thank you. باي. رمضان كريم.
رمضان كريم.